This is Jerry Hesch with the Hesch Institute. Interesting case we have today, and we're titling this Ankles SIJ Whole Body Patterns. I'm with the Hesch Institute in Henderson, Nevada, very close to Las Vegas, Nevada. HeschInstitute.com is our website. We do consultation, treatment, seminars, and distance learning, treating articular and dense connective tissue and pain restrictions throughout the whole body. Thank you. We'll demonstrate her gait pattern. We want to focus on the legs. We're going to keep her face out to preserve her privacy. So if you just walk up and down like you did before, you'll see a very rigid body type. Okay? Very rigid. Very minimal. There's no pelvic motion. There's hip motion, but very little pelvic mobility. Right arm, of course, is much more rigid. Let's have you now lie on your back, and we're going to have your feet down at that end. Thank you. So, multiple ankle injuries. All right, you can see that hips are tight and they're maintained in external rotation on both sides. And if we try and bring them into neutral and a little bit beyond, you'll see about 10 degrees of internal rotation. Might be 15, but it's not much more. There's a very hard end feel, so we distinctly want to work on gaining that mobility. I should think for your body type, I would assume that about 30 degrees to be your norm. If I'm wrong, then it has to do with how your hips have developed, but I think those are changeable. Dorsiflex is very limited on both sides at 0 degrees. It goes just to neutral because the tali are very forward. You can see the tali, at least I can, are forward in relationship to the tibia. I don't discern weakness. Very, very strong athlete here. There is definitely laxity in inversion, recurrent ankle inversion injuries. Because the tali are stuck forward on both sides, the ankle functions in neutral down to full dorsiflexion. In this type of talocurl-talocalcaneal articulation, the subtalar joint gets very restricted. So she has minimal motion. I cannot evert it much, I cannot invert it much, I cannot abduct it, I cannot adduct it. And if I block ankle motion by squeezing the malleoli, that is so minimal. Okay? So I believe that we can restore that motion. The pelvis, when I do pelvic spring tests, and I've already screened her hip, we're bypassing the hip. When I push on this pelvis, you would say, that's mobile, but actually the whole pelvis rises immediately. So when I take up the slack throughout this structure, and then I try and impart a spring test, it's extremely rigid, and I would say there's no motion going through the pelvic joints. And on this side, it's the same drill. There is an absence of pelvic side glide mobility right to left. There's an absence of left to right pelvic mobility. As a matter of fact, there's no pelvic mobility in any direction. Please lie on your stomach. And that's because the sacrum is stuck in posterior glide. So one of my questions was, do you have urinary frequency? And the answer is yes. She has to get up 3 times at night to go. And the lower sacral nerves are traction. This is not your norm. This is a traumatic event. Very active athlete, jiu-jitsu expert. I mean, you've taken some falls on your bum, and there's just no sacral spring whatsoever, no pelvic mobility anywhere, no superior glide, no inferior glide, no movement at 4, at 5. Tender L4, no doubt, it takes up the brunt. You have mobility throughout your rib cage and T-spine until we come up to about T3 to 4, right there. It's very, very rigid. If you would lie on your back now, please. So you can also test that by springing sternum, and you have good mobility until we come right here, upper body, just below the manubrosternal junction. Very rigid upper body. I can't get any AC joint mobility. And if you want to come out of the way, I want to show, we can keep her face out of the film, very rigid suboccipital region. Okay, I'm trying to traction her head with a normative amount of force, and there's no movement going through the rest of her body. I'm trying to lift her head up with a normative force. No, I'm trying to spring C1. C2 gets a little give. C3, boom. 4, boom. 5, down. Normative mobility. But upper cervical is so rigid, and I'm going to contrast that. I'm going to have Tony come lay down. So Tony, come lie on your back. And Tony is also very physically fit, very athletic. And if you can just capture part of his head, when I capture his head, normative amount of force, movement translates through his whole body. Can you show the feet, please? Same normative, very light spring, and it translates all the way down to his feet and ankles. So, in conclusion, Jen's upper cervical is very rigid, and that's a common pattern we see when the sacrum is stuck in posterior glide. So I submit that with Jen, in the next 20 minutes, we're going to work on gaining ankle mobility, subtalar joint mobility, hip mobility, and internal rotation, and we're going to create mobility through the SI, which should then reflexively release and allow movement through the sternum, through T3-4, and the upper cervical. So we'll stop filming here. Thanks.